First thing, okay, the largest features possible. Okay, this down here, okay, the tip, it's called the apex. Okay, it's called the apex because it's sharp, right? And the top, okay, this would be called the base. If you kind of imagine coming along here and just slicing all these vessels off, you'd have a flat surface. That would be the base. Okay, so the base and the apex are named for their shapes. They're not named for their locations, okay, like you expect the base to be on the bottom, right? The next thing is, with the heart, right and left are a really big deal, okay? So I've already talked about that in lecture, that the right and left have completely different functions, so you have to keep track of them when you're looking at the model in the dissection, okay? And obviously you can tell the top from the bottom, okay? The way you get left and right is there's a way to tell anterior from posterior. So, the model, surprisingly, does not actually show it that well. It shows up better on the dissections. So I'm going to do the dissections on Thursday. Okay, so what you're looking for, what you're keying off on, is, see there's a sulcus here, okay? A sulcus is just what a sulcus was in the brain. It's a groove. Okay, so this sulcus, okay, is the anterior interventricular sulcus. Okay, look at its shape. It's straight. Okay, it goes straight off to one side. It never looks like it's going for the tip. Okay, so on the anterior, okay, that's the way the sulcus goes.
When you're looking at the anterior and posterior, is there more myocardial tissue on one side or the other? Or is it split fairly evenly?
It's split fairly evenly, but but that depends on which angle you kind of look at it from. Okay, it's on the model it looks even. On the dissection, it's hard to tell. The dissections, I don't know, did she talk about this at all? The dissection is much more difficult than the model, so you really do want to look at the model carefully. Okay, so this is the anterior interventricular sulcus. I would say that, relative to the brain, okay, there's a much bigger difference. On the posterior, okay, there's a posterior interventricular sulcus, okay, and it looks like it's going straight for the apex, but then it curves off, so it actually kind of winds up in the same way that the anterior does. It does go off to the side, but it has a different shape, like a little J shape, okay? So that's the posterior interventricular sulcus.
Do they connect?
No, because they have to go through the apex to do that. They don't. Okay. So you want to keep that straight. The other way to tell, which you'll sometimes see, and I don't think the model illustrates that all well, is that some people tell from like the shape of the apex that it's like sharper in the front and blunter in the back. I find this a lot more definite. When you're trying to decide is that sharper or blunter or something like that, you kind of go back and forth. Okay, so now that we know that, so anatomical position, this is anterior. Okay. These blood vessels coming out of the top, okay. Again, okay, they're somewhat difficult to recognize on the model. They're much, much worse on the dissection. In particular, on the dissection, there's all this fat and connective tissue and stuff like that up here. Okay? And so it's really hard to tell what's coming out of here. Okay? So you pretty much have to learn them in order. Okay? I mean, that's what I do. Okay? So